I wanted to introduce Dr. Rohde briefly, um, as brief as I can, because his bio is very long.
Yeah,
Uh,
just quick.
yeah, quick. Dr. Rohde is a professor and chair of the Clinical Laboratory Science program in the College of Health Professions at Texas State University. He is an associate director for the Translational Health Research Center, as well as a fellow of the Association of Clinical Scientists, and honorary professor of international studies. He is an ASCP board certified specialist in virology, microbiology, and molecular biology. He spent a decade as a public health microbiologist and molecular epidemiologist with the Texas Department of State Health Services, Bureau of Laboratories and Zoonosis. Sorry, I couldn't say that.
Okay, zoonosis.
Zoonosis Control Division prior to his academic career, including 2 terms as a CDC visiting scientist. His research interests include healthcare-associated infections and antimicrobial resistance and clinical public health microbiology. He has published over 75 research articles and abstracts, 2 books, and is a highly sought keynote presenter with over 100 international, national, and state conference presentations. And that's not to mention what he has going on this week. But without further ado, Dr. Rohde, I will let you take over.
All right, thanks, Uriel. It's an absolute honor and privilege to deliver the distinguished lecture today for Alpha Chi. I'm really thankful and grateful. As I was mentioning to the host as we started, it's especially exciting for me because I get to brag on Texas State a little bit when we talk about our measures for the mitigation of what's been going on the past year. So I'm going to share my PowerPoint now. And if you have some questions at different points, please feel free to put those in the chat and we can address those as we move through the talk. Okay. So I've addressed this talk with respect to a number of things, but with respect to a pandemic and thinking about any lessons learned, I hope that I'm going to be able to share some of those insights as we go through the conversation today. And really the context for this talk is really looking at emerging and re-emerging pathogens with respect to a global pandemic. We obviously know now, if you've been watching, reading, and listening during the past year and a half, that a pandemic is a really complex issue. It's not one single thing. It's not even one single thing related to a virus. There are many other factors in play that kind of pushes us over a tipping point. And so from my perspective, as Uriel mentioned when he started, I've got a little bit of a unique background because I spent a decade in public health, in the trenches of public health at both CDC and Texas Department of Health. And then I came into academia and worked in healthcare and training medical laboratory professionals. So clinical laboratory science is the major in the College of Health Professions that prepares individuals to work in the medical laboratory in a hospital setting. And when you graduate, you sit for a credential. And I have those credentials, and so do my students. So here's our objectives, and without reading them to you, I want to give you an update, literally up to the moment today on this pandemic, as well as a little bit of information around Texas State's plan for how we handled that over the past year. I want to talk a little bit about treatments and vaccines. There's a lot going on with vaccination right now. And then if we have some time at the end, if you guys don't mind hanging with me for a little while since we got a late start, I'd like to talk a little bit about emerging pathogens with respect to what might be coming next. There will be a next outbreak, maybe not a pandemic, but certainly we have multiple outbreaks and epidemics during my 30-year career, and I would expect we're going to continue to have those. So let's take a look back, right? So I don't know about you guys, but last December and January, I had my eye on this, this virus that was causing pneumonia-like illness and wiping people out in Wuhan, China. And so I'm constantly watching that landscape in general. And then on February 11th, we all know that that's the date now that the World Health Organization actually named this pandemic, even though things were happening before that. And one quick pet peeve of mine is that There is a difference between using the terms COVID-19 and SARS-CoV-2. So COVID-19 is the disease, the infection, and that stands for corona, CO. Virus is the VI, D is for disease, and then 19 is the year it started. SARS-CoV-2 is the actual virus agent. So you might hear me identify that as we move through this today. Just a little context, most of you probably had multiple coronavirus infections. It's in the virus family that causes the common cold. Up to a third of humans have had a common cold caused by this virus, primarily transmitted through the air. Rhinoviruses are responsible for the most common colds when you deal with them. And there are 7 coronaviruses that we think about when we think about humans. And there's not an exam over all these nomenclature here, but I did want to mention that you probably heard of SARS. That was the first time we've noticed that in 2003. The acronym stands for Severe Acute Respiratory Syndrome. And then about 2012, 2013, we dealt with Middle East respiratory syndrome, started out in camels of all things, and then moved into humans. And now, of course, we have SARS-CoV-2. Those 3 have been ones that have truly made us take note of the mortality and the morbidity. They are zoonotic agents. That means they typically have reservoirs in animals. They certainly can evolve and infect people. We've seen that now not only with SARS and MERS, but very likely SARS-2. And they're named for these crown-like spikes on their surfaces. And so when you look at this, and this is a famous image, many of you have seen these images now across the landscape, this is a typical virus. Viruses are simple little things. They are basically a nucleic acid, in this case RNA, wrapped in a protein. And sometimes they have an envelope, which is more fat. And that's it. They don't have organelles like mitochondria or anything else that you see in a eukaryotic cell. They are very simple organisms, and yet they're very diabolical, responsible for some of the more deadly events in our history. Here's one I want to point out. This is a spike protein. You've heard a lot about it. It has a unique shape. We've learned a lot about it. I'll be talking about it today when we get to testing and vaccinations. That's the primary target for your antibodies to attach to. It's the primary target for the vaccines to produce antibodies that recognize the S-glycoprotein. And that and the RNA is the primary areas for rapid testing or PCR-based testing, which is the genetic-based testing. Here's just a quick cool look at a transmission electron microscopic image. This is the first US case that we know of that came in through Washington State. And you'll notice the little blue spherical areas are the actual viral genome. So this is cell material, and then the tinier viral particles there. Most of you know this, but viruses are down in the nanometer range. You cannot see these with a typical compound microscope. You need transmission electron microscopy. Apologize for that. Okay. Here are the 3 that I want to do a quick update on. So in 2003, the first SARS hit the world, and notice that the mortality rate was around 10% out of about 8,000 people. But notice also that it stayed kind of put in roughly 29 countries. So ultimately, that slowly kind of faded away. There's still cases that pop up. In 2012, 2013, we had MERS pop up. This one really caught our eye because of the mortality rate reaching about 30% or so. A few less cases, but a few more deaths, and about the same number of countries. When you move into 2019 and the current outbreak because of SARS-CoV-2, it's been a different story, obviously. We now have almost a full global pandemic encompassing almost every country and territory around the world, about 219 of them, almost 130 million cases worldwide, and about 2.8 million deaths. That's as of March 31st of last week. Just some other quick things. If you're not familiar with the Worldometer, this is a great site along with Johns Hopkins and some other sites that have been tracking this. And you can look at the USA. We're #1, unfortunately, in cases. So we're over 31 million now. We're pushing more than this. This was last week. This shows about 564,000 deaths. And a quick point to what my world deals with in the medical laboratory and public health world. We have now conducted in the United States over 400 million tests. I've done many talks in the past 6 months, 8 months about our profession. We are burning it at all ends, and many people are worn out, working nonstop and dealing with this high demand testing. You can see where the rest of the world in the top 10 kind of sits. Unfortunately, the USA, doubles and almost triples many countries in respect to deaths. And here's something that I like to point out. You've heard Dr. Fauci point this out and others around the world, that it's unfortunate the United States, we only have about 5% of the global population, but we're responsible for about 25% of the cases. So we have not done a great job on limiting the spread of this virus throughout our population. Quick heat map. I don't want to spend a lot of time here. This is just a visual for you. So look at the world, right? So this is the world as of last week, a little before last week, March 23rd. And the hotter the area is, the more rapid the transmission, the higher number of cases shows bright red. So you can see the United States, parts of South America, certainly through Asia, a little bit in Africa and elsewhere, have many more cases than up here. Now, remember, up here, there's not a lot of population, so that's why there's not a lot going on up there. If you're interested in the United States, here are the top 10 states. You can see all 50 ranked if you want to at these websites here. Again, this is the Worldometer site. Texas and California have bounced back and forth between number 1 and number 2 over the past 9-10 months. Right now, California is sitting at that number 1 spot with over 3.6 million cases and about 92,000 deaths. Texas is right there with 2.8 million cases and more deaths actually than California. And so this, if you look at the deaths per 1 million in population, that sometimes is a better stat to look at because it takes into account per 100,000 or per million population, depending on what you're looking at. And again, just a quick map. Harris County, which is in Houston, Texas, if you don't know about Harris County, that's the 1, 2, 3, 4, 5, 6, 7, 8th highest county for numbers of deaths in the United States. Los Angeles is the number 1 county. And again, you'll notice that when you lose population density, things cool off because this virus is primarily spread through respiratory transmission routes. Some of the risk factors, again, many people know this, but they're complex. And so we have behavioral risk factors, everything from hand washing to distancing to wearing a mask. We have, comorbidities like obesity, diabetes, and autoimmune diseases. Demographics, where do you work? Ethnicity plays a part in this, access to healthcare, and then even age, of course, plays into that. And in some cases, even gender plays into that. And moving forward through here and talking about some of these risk factors, one of the things we've really learned over the past year, you might remember at the beginning of this outbreak, a lot of emphasis was placed on this bottom arrow down here on the disinfection and the concern with surfaces. It is not negligible, it is not zero, but as we followed through in the past 6 to 8 months, we now know that the primary way this is transmitted is through respiratory droplets. Otherwise, cases would be phenomenally out of control if we had real issues with surface contamination. And of course, when you throw in the massive cleaning and disinfection of surfaces, that probably helped a lot as well. The research and the epidemiological data shows that masks work. Hopefully you understand that. This is something that I continue to talk about in the public and with healthcare professionals. Early on, of course, people were talking about N95 masks being the best route of protection because they actually filter down to the size of virus particles. But what we know now is that many viruses will sit in respiratory droplets that are the size of bacteria, and regular masks, surgical masks and cloth masks do help impede sometimes up to 60 to 80% of your respiratory transmission. And when you have both people wearing them or people in a crowd, you have the lowest risk. There is, I mean, pretty much unrefutable proof at this point when you look at the epidemiological and experimental data around this, regardless of what you're seeing and reading by those who may not think it's happening, it's absolutely an effective measure in slowing down the transmission of this virus. Got to work on, I'm not going to show you this video just due to lack of time. You may have seen it. I did some early experimental design showing the effectiveness of N95 cloth mask and surgical mask using Texas State students. Here's the link if you would like to watch that if you haven't seen it. And it shows not viruses growing on plates, but it shows bacteria. But what we showed was that these types of masks absolutely reduce respiratory droplets from being transmitted to a typical petri dish that will grow bacteria. So again, just kind of a nice visual for people to understand that these masks certainly inhibit the transmission of those respiratory droplets, which contain virus and other particles. So here's kind of the take-home message around risk in this virus. If you haven't seen some of the published data and peer-reviewed data, there is a risk factor for Hispanics and African Americans and some other peoples of colors, probably due to various reasons of socioeconomics and other risk around access to healthcare, up to 3 to 4 times the risk for African Americans and Hispanics. Disabilities, developmental and behavioral disorders, pregnancy as a form of autoimmunity or immunocompromisation, homelessness, obviously for various health reasons. And then I tossed this one in here because this has been an ongoing issue that a lot of people don't know about or read about, is crowded living within jails. I've been following this from the get-go. I've done some legal work in this area with inmates that were very concerned about this. So these are all kind of high risk. And the take-home message, immunocompromised individuals. And again, you might think that doesn't include you or someone like you if you're kind of younger and not doing these types of risky things. But if you're packed into crowded living areas, or you're doing risky behavior, not wearing masks, you're traveling into high transmissible areas, that raises your level of risk. Super spreader events are real. Again, the data and the epidemiological evidence have shown time and again these events that have happened without social distancing, without masks, without being careful, absolutely are seeding large spreading events. Looking back, this is kind of an interesting graph to take a peek at here. If you can see here some of the numbers here, if you look back at the beginning. So remember, we kind of kicked all this nastiness off in January, February of 2020, and we started seeing those cases uptick. Remember, we shut everything down early. And even with that shutdown and the closing down of areas before we really were pushing masks and watching crowding and things like that, we had our first surge. So right around the 1st of April, so about a year ago, we had our first surge. This represents about 9.7 infections per 100,000 residents. And then we had a dip. And then around that July 4th holiday into Memorial Day time, we had another huge rise in a second surge, about 20.5 infections per 100,000 residents. Then it dipped. And then this past fall, you'll remember the really nasty rise as we got into, this was the whole area around dealing with New York and some of those other states, nursing home issues all through here. Just went crazy up into that time frame around late October, November, and so forth. And just to kind of give you some highlights or maybe lowlights from that past year, you might remember around October 23rd, that seems crazy that we had 83,000 plus cases. But then as you move forward quickly, as we know viruses do, when you get a novel virus into a naive immune population, so people did not have immunity to this virus, right around the presidential election, we reached a new record higher in the number of daily infections that surpassed the mid-July peak. So around November 4th, we had our first kind of big news story around 100,000 deaths. And then look how quickly that doubled. November 27th, so Thanksgiving, we had 200,000 deaths. January 2nd of 21, we hit 3,000 deaths. And then we hit this crazy number in February of 21, where we pushed it over 5,000 deaths in a single day. And that happened for several days in a row. And you might remember some of the conversation around, COVID being some of the top 10 deadliest days in United States history, surpassing these major other natural disasters or wars or battles or things like that, or even 9/11. So very frightening to see some of that happening. Some more epidemiology here. This is where we sit today, 570,000 deaths. This is looking about a week ago, just to kind of show you that we had, and I'm going to talk about this as we move forward, we've had some great news really since February. We've started trending downward. So you can see this trending downward on this graph on both sides here, where we're trending down. We're definitely getting lower cases if you look at the data collectively across the United States. What I'm going to show you in a minute is that that's not totally true. When you look here, this is from, again, using sources from Harvard and the Johns Hopkins predicting modeling and looking at what's going on right now. And maybe you've heard some of this or followed this. Minnesota, Michigan, these other states up in the Northeast are really kind of rocking and rolling again with respect to cases. So these are places we're keeping an eye on with respect to new variants being transmitted. Michigan right now, almost 5,700 new cases a day. Again, this was April 1st when I pulled this down. That's a plus 125% change over a 7-day period. New Jersey, New York, some of these other states are also pretty hot. So when you look at this map, this heat map, these are areas that public health and healthcare are really concerned about right now. And so we're really watching those. You might have even heard this week that President Biden and CDC and others have rushed more vaccine to this part of the country to try to get more shots in arms to help put that fire out a little bit. Okay, a little bit of a transition. I'm not sure if there's any major questions right now from anybody. I'm going to transition to, I keep moving this, I'm sorry, I'm trying to get my information here to show about the Texas health kind of information, so the Texas state information. So I had the honor again and the privilege to be appointed by the president to a couple of those different work groups that Texas State put together last year. I sit on the Health and Wellness Safety Committee for COVID, and I sit on the Research Committee. And I've had just a great time working with Dr. Karanko, our medical director here at Texas State, and working through these kind of 12 guidelines that we've really been following. I don't want to read this to you. I want to give you some highlights because I'm really proud of what Texas State has done. Texas State really early on adopted and followed the science, even as it changed, because science does change. But to the credit of our leaders, they adopted masking on campus. You might remember that may have been a little controversial last summer, but we did it. And it absolutely has been effective, as well as our other distancing, other social gathering issues and things like that. So even after Labor Day, so after about 8 weeks in the fall semester, even after Labor Day, we had kind of as expected, when people come back from summer, and a lot of people weren't here on campus, we had kind of a somewhat high positivity rate. And that was the highest time we saw that. That was about the 4th week of classes in the fall. Once we hit October, we dropped down to 30 cases. They've declined over that time and moving forward, even though we're testing more. So let that sink in a little bit. We're testing more. We went from 500 tests to 1,200. Sometimes we hit 2,000 tests a week, and yet the positivity rate has lowered. That shows that our mitigation measures and our work has really helped at Texas State. And really, if you look at COVID-19 cases and positivity rates, they've been trending downward in Texas over about the past month or two. And we went from almost 21% in January to almost 12% in February. Texas State has also fallen off. Look how much lower we are, 4.7% during the first week of classes. We were always concerned anytime you bring everybody back after a 5-week Christmas holiday, but it wasn't horrible at 4.7. And we've been down around 3 and even less than that, 2.5, 2.6% right up to last week. So we continue to be low, and I'm going to show you some of that data in a second. So things that really worked at Texas State was we got on top of masking, we got on top of distancing, we kind of mitigated and eliminated major gathering events and things like that. And we've tested because we know that asymptomatic spreading is important. And when you test, I'm going to get on my soapbox a little bit here about public health. Testing really matters because it helps you figure out who's asymptomatic. That's the crucial danger. And then the next thing you have to do is contact tracing. And I think Texas State's probably done a better job at contact tracing than the state of Texas in some aspects, and the country for that matter. I've done contact tracing back when I worked at the health department. I've done it for West Nile virus. I've done it for some other flu outbreaks and things like that. It works, but it's absolutely hard work. You must have honest, transparent reporting, which our students have been really good about, and our faculty and staff. And then you have to follow up with the tracing. And you have to have people following the rules of quarantining and isolation. And I think we've done a really good job of that at Texas State. And we have to keep kind of practicing this, even though people are getting a little antsy and they see these numbers dropping and vaccination is going up. These are all great things, but we haven't quite crossed the goal line yet. It's not time to spike the football. My hope is that we can maintain those habits at least until about June 1st, and see where we are with vaccination rates and see what's going on with our epidemiological data. I was a little disappointed when Governor Abbott announced that masks were kind of going away as far as he was concerned and leaving it up to local and other individuals. Again, I'm speaking at this from a totally public health standpoint, not a political standpoint. That's a bit of a worry because we still don't have enough people vaccinated to kind of slip back into risky behavior. So please continue to push that message with your family and friends. We've been very fortunate that Dr. Karanko got us on board for the vaccination hub out of Texas. We are doing that. You guys have seen that. Here's a little pull of data from our website and showing you that we've been sticking arms here since about March 9th. I was very fortunate in my college because all of us are in clinical sites and hospitals. We got a lot of vaccines going back in January and February. So my entire faculty and about 80% of my students are fully vaccinated. And we've been in person since fall because we just can't teach medical laboratory Zoom. We did the lectures that way, but we can't do our laboratories that way. But look at these numbers. If we continue with this weekly, and if we get these up even higher, we can have the entire student population and faculty and staff vaccinated in the next month or two. And looking at freshmen coming in, we can maybe even open that up in August to freshmen before they start. So I'm really looking forward to the supply as it continues to rise, and that continues to help with herd immunity. This is a snapshot as of March 31st. There was about 88 active cases. You can see this is all the way back from March 1st, 2020, when we first started keeping data. About 2,200 student cases, about 250 faculty cases, almost 2,500 total. Now remember, when you look at data, we have not tested every single person on this campus. This is a snapshot of the people we have tested. There's obviously some plus and minus on the data that we're always having to think about, but this gives us a weekly good snapshot of what's happening within our population and what's circulating. And when you look at Texas State, Hays County, and Williamson County for Round Rock, you can kind of see We've done a pretty good job. We've done better than the counties that our schools are in. So one of the things Dr. Cronco and I like to tell people, you are safer on this campus than almost anywhere else, unless you're sitting at home with family and you're not getting outside that bubble. So being on this campus has been a pretty safe place. It's when people have left that we've had positive cases peak up. And I just wanted to show you this as we kind of get away from this area here. This is last fall. This is about a week ago. So notice the positivity, about 2.5% or less, and look at this late March, about the same thing. So we really have done a nice job over that time period at keeping that positivity rate down. That's really good. So as we kind of transition here a little bit, just want to mention that again, the best way to prevent illness is still to avoid being exposed to the virus. Just don't get the viral infection. That's not easy to do 100% of the time, but it's certainly a way to mitigate that from happening. These are all things you've heard over and over again. It's all still true. This is an interesting thing to follow through CDC efforts and watching school classrooms and things like that. We think 3 to 6 feet might be doable going forward, especially if people are, you have some vaccinees in the population and things like that. So that may be something to keep an eye on. I would still practice 6 or more if you don't know someone and you're packed into a place. I'm just going to make one quick comment about the mask again. Don't let the perfect be the enemy of the good. Don't let social media trolls, don't let other people talk to you about, Fauci at one time said that masks don't work. All of that was taken out of context. N95 masks are absolutely the best mask. But as we learn more and move forward, we certainly realized, as science tells us to do hypothesis testing, that we adapt to the data. And we now know that masks, even cloth masks and surgical masks, do a really solid job of blocking respiratory transmission, especially if both people or everybody in a closed area is wearing one. And ventilation, we've really seen ventilation being outside, eat outdoors, do things outdoors is a really good thing to be doing. Here's kind of our toolbox. You've probably heard of many of these on treatment therapy options. So we've got an antiviral remdesivir that's been used over the course of, about 8 or 9 months of this pandemic, still showing some usefulness. Convalescent plasma, this is when you take the plasma from someone who has recovered from the actual infection and use that in another person to try to help treat them, to give them some passive immune protection. Monoclonal antibodies are when you create those antibodies in-house in, say, a animal model or in cell culture. And you might remember President Trump receiving Regeneron, the cocktail that had 2 monoclonals in it. One was from some of the original patients. The other one was from another patient that had a strong response, Eli Lilly. The thing about the monoclonal antibodies, if you've had anybody that's taken them or asked you about them, it has to be early on in the infection, like 7 to 10 days, max 14 days. When it gets too far out, they've not seen as much efficacy, effectiveness for those monoclonal antibodies. Steroids, just knocking down the inflammatory issue with your lungs, and the flooding of your lungs helps a lot. And even positioning the patient on their stomach has been helpful with respect to fluid on the lungs. Now, before I jump to vaccines, one of the things we're watching is how the variants, how the virus evolves, how it's going to affect not only testing, because those spike proteins are changing or something's going on with the key and lock fit, but even the treatment regimens around monoclonals and things like that. So I'll kind of mention that as we go forward. That's something that we have to kind of monitor real time. We're already tweaking some of our testing things because we know that new variants aren't being picked up as easily with the old testing parameters. So that's just something to keep an eye on. I'm going to kind of hit vaccines in a bit. I want to save those towards a few slides down the road here, because first I want to talk about virus evolution, virus mutation. One of the things that kind of drives us crazy in the virology and public health world, and maybe the healthcare world, is it seems like every time something happens, there's a new crazy scare headline. So what I want to tell you is that be careful that you don't believe every headline about, mutant virus is out of control or something like that. And here's why. It's worth understanding and being aware of, but it doesn't always mean the end of the world with respect to what we're doing. So viruses replicate. They're some of the most efficient replicators out there in the world of microbes. And they have copying errors, even as they undergo copying. And I want you to think about this. If you've ever played the game telephone, where, if I told Uriel a story and he told Dr. Williamson and she told Twister, and we did that quickly without any correction, over time, that story is going to be totally out of whack after multiple copies. That's sort of what happens with copying errors. The more times the virus mutates, you can have these kind of genetic mutations. Many times it's not going to do anything, and it might even be lethal to the virus. Okay, so keep that in mind. These are natural things. Every virus family does it. It's not a new thing. Viruses do this. But sometimes when these changes occurs, and you'll notice in this picture, just a nice picture here to show you what's going on. Look at these surface lollipops. So think about those being on the outer surface of a virus. Viruses, again, are nucleic acid. This, by the way, is influenza because it has 7 RNA segments, and it's got some lollipops here on the outside, these antigens, these markers. They mark cells for what they are. Every cell in your body has these as well. For when you get a transplant, you have to make sure there's a match. But viruses and microbes have them as well. And they tell our immune cells that they are foreign, right? They don't belong in your body. And so your immune system attaches and activates your B cells and T cells in some instances and creates antibodies, and other things get put together to start neutralizing that virus. So those markers are important, right? And so when the virus evolves, especially these minor changes called antigenic drift, it means that your immune system, especially the antibodies, are not going to bind as effectively on the surface markers. So again, if you look at virus A to virus B, we've had some mutation. Here the antibodies were fine. That's a picture of an antibody. They're typically Y-shaped, has no problem latching on. Think of a key in a lock. Think of something sitting down almost perfectly in a receptor kind of shape. Shape matters greatly in the immune system. And what happens is you see different proteins now, different lollipops on the outside. Now you have these kind of rounded ones and not flat ones. And so the antibodies will not recognize those as well, but they still will recognize these. So there's partial fit, there's partial neutralization. We deal with this every year with the flu vaccine. Sometimes we're right on, sometimes we're not. And so this basically means you're less immune to that virus variant. It doesn't mean you're going to, drop dead. It just means that you're less immune and you might have some issues. You might get sick, but you might not go to the hospital. You might get sick, but you may not have any mortality. Okay? Here's the more problematic issue, and that's when viruses shift. And this is a major change. And this is more dangerous because it can create kind of a new or novel strain. Influenza is diabolically famous for this because of all of these different RNA segments. Here's influenza 1, here's a different strain, influenza 2. They both enter a cell at once. Sometimes this could be a human, but often it's a pig. It could be a bird, and they will mix. Pigs are known as the mixing pot with influenza. And look what happens. You get this new virus, and you see different colors here because now it has different types of RNA, and you have different surface markers, different lollipops popping out, okay? And what that ultimately does when you have reassortment like this is you get a new virus, and you have a different mixture of antigens on the surface. And when that shift happens, major shifts means that a lot of people will have little or no immunity in it. And you can kind of see just kind of picture wise, what can happen is the public, you might have a small percentage that have seen that virus immunologically, but a massive number will not. And we even talk about this in years that we don't predict the flu vaccine well. That's an entirely different talk, but we do that every year. CDC does that with WHO. There's different types of virus, different types of antigens in those vaccines, depending on where you live in the world. And sometimes we don't predict well, and it's only 50% effective or 60% effective. And so it just happens. It's just kind of the way you have to go with the predicting of new strains. Now, the good news is that coronaviruses don't have those 7 segmented genomes. They don't reassort. They have one single long piece of RNA, but sometimes when you have 2 coronaviruses getting in the same cell, they'll do something called recombining. Not reassorting, but recombining. It's a little different. It stitches the 2 together, and sometimes that means you might end up with a novel coronavirus. And that very well may be what happened with this. We're still trying to figure out if it was a bat kind of origin or something else, but certainly it can be this recombination event and have kind of a similar pandemic consequence because you have a novel strain, right? So influenza, just kind of a quick thing to remember. Some viruses reassort, other viruses recombine, and many times you'll see flu kind of compared to corona, but they are different in how they utilize their genetic material and how they recombine or reassort. So that's going on all the time, right? And so this brings us to this topic of variants. So this is very much on everybody's mind right now. And again, I'm going to try not to read this to you, but if you have questions later, feel free to ask. The US government a few months ago created an interagency group. This is everybody from CDC to the bioterrorist group to NIH, and so on and so forth. There's the Homeland Security group. There's about 6 agencies, and they sat down with leading scientists and virologists and came up with a variant classification scheme for this pandemic. Okay, and what we typically do is we monitor variants in the United States through sequence-based surveillance. So you have to literally, and this is kind of important for those who don't understand molecular diagnostics, it's one thing to get a positive rapid test, a positive test versus a negative, but you must sequence that virus to know if there's any changes in the virus, in the RNA genome. And so that's another level of testing. It's a reflex test. And in all honesty, I'll get on a little soapbox here in a minute. The United States has not done a great job in funding public health and having these measures in place. So now we're kind of backfilling, unfortunately, knee-jerking retroactively. This is always a problem. Many of us scream about this all the time. And so we're trying to catch up that sequence capability across the US. We were at about 1 to 2%, which is pathetic. We're pushing 5% now because universities are helping public health labs, and hopefully we'll get up to 10 or 15% as we move forward and keep it there for future issues. But here are the 3 classification schemes that kind of you may have heard. Variants of interest, low level, variants of concern, that's where we're at right now in the US, and variants of high consequence, which we do not want to go to, okay? So these are the variants that you see circulating in the US. I'm going to talk about them in a minute. 117, 351, P1, and in some cases P2, 427, and 429. These are all classified as variants of concern. I'm just going to jump to the one that, so when you think about those levels, the variants of interest are on that low level. That means that they're not causing any trouble. We can easily test for them. They're not causing a lot of mortality, so on and so forth. Variants of concern, on the other hand, is what we've been experiencing from probably the beginning, is you have high transmissibility, you have serious disease, you have really high hospitalization, you have mortality issues, you don't have a lot of luck, at least early on, with infection or vaccination, and so things like that. And so I'm not going to read all these bullets to you, but this is what we're looking for. Is there impact on diagnostics? Is there impact on transmissibility? Is there evidence of disease severity? And that's kind of where we've been for quite a few months now. And if you look at this, and again, without reading this to you, here's this is from CDC. You can find this on their site. Here's the lineage, the pango lineage. And you might realize that sometimes we link these to where they're first detected. So B117 was first detected in the United Kingdom. P1, P2 is mainly out of Brazil, but some in Japan. South African is 351, and I'm going to jump forward here. These two are California variants. Again, low increased transmissibility. There hasn't been a lot of impact with these, but we're watching them. So sometimes I like to talk about this because in all things politics and elsewhere, you hear people talk about blaming a certain area of the world. That's ridiculous, all right? Viruses don't care where they're born or where they originate from. They just want to amplify and mutate and cause havoc. So right here in the United States, we have our own variants that are originating and changing. It doesn't have to be just from China. It doesn't have to be from the UK. These things pop up all over the world all the time. Here's why we're watching 117. We believe there's increased transmission. We believe there's some issues with some of the therapies, the monoclonals and things like that. So we are closely watching this. And why we so desperately want to get people vaccinated quickly is because if you get people knocked down and you get them immune, you can help slow the emergence of a new variant. If you don't, then you might have a new variant emerge and have kind of a fourth surge, if you will. So that's kind of our concern right now. P1, 351, these are more moderate. 351 is showing a little bit increased transmission, but it's not showing as much effect on treatment therapies and vaccines and things like that. So that's good news. And we'll keep our eye on these California strains that are messing around. Now, just to kind of mention, here's the one we don't want to deal with. We don't want anything getting to high consequence because this means what you think it means. Failure of diagnostics. Vaccine effectiveness falls off really bad, really quickly. There's reduced susceptibility to therapeutics. There's increased disease and increased hospitalization and likely deaths. All the types of things we don't want to see again. And so if that happens, that typically requires a public health emergency of international concern. And again, we go kind of back through the start of another wave and another concern of dealing with that. Right now, there are no high consequence variants in the country or in the world, but we certainly are going to be watching for any issues around that. Hopefully that will not occur. Quickly, due to time, here are some of the different variants that I just mentioned. So you can go look at these on CDC now. We're mapping these. Remember, public health surveillance is passive. We're not testing everybody. This is not a perfectly accurate snapshot of anything. It's a snapshot. It's a snapshot of what's going on in the United States. It's not perfect, but it gives us good data to kind of understand what's happening in different areas of the country. 117 is the highest right now. There's our South African origin and there's our Brazil origin. So those are the ones we're watching. And just a quick thumb through these slides so you can kind of see. Here's that United Kingdom 117. The hot spots kind of happening up here in Minnesota, Wisconsin, Michigan, some over here in the Northeast. Florida continues to be kind of a warm state. Texas is kind of warm, and so is California. Now remember again, perspective for population density matters. You don't have a lot of population up here in Montana. You do in Texas in certain areas and Florida. So you have to kind of look at that with that understanding that those numbers can mean things, and you really need to look at that per 100,000 population or something like that to kind of try to compare. There's P1, not as warm throughout the US. There's the South African variant, also not as warm throughout the country. Now this is a busy slide. I almost didn't put it in here, but I love it as a virologist. And so I'm just gonna leave it here and let you kind of take a peek at this. This is the variants of concern. And this is a family tree, if you will. This came out of Public Health England. I have a colleague there that shared this with me, and I just love the slide. And you can kind of see the root lineage and kind of how it came through. The one that came through Seattle actually is extinct now. And notice that the beeline lineage is really the one that became fixed and really became transmissible. These are all different variants. There's the, as you come over here, there's the B 351. That's the South African we've been following. There's the UK one in Kent. And so these are kind of interesting to watch. I'm not going to get into this for this discussion, but some of the original changes in the spike protein gene had to do with a single coding amino acid that made that spike protein a little bit different shape, which means testing might change, which means vaccines can change and therapeutics can change. So I don't want to leave you with concern and worry. What I want to leave you with is how phenomenally amazing this is that in 2021, we have the ability to follow this in real time. This is crazy amazing to me as a virologist. I've been doing this for 30 years. One of the single most phenomenal things in my mind that has happened during this pandemic is how well we have adapted our technology and quickly, globally, even though we have issues around the world, have kind of put these things together with respect to cranking out vaccine and testing with a real-time mutating virus. It's just unbelievable. And so it gives me hope moving into the next decade or the next century that we're going to be able to respond in real time to new vaccines, to new therapeutics, and not having to wait 3, 4, 5 years, but to respond in months, if not a half a year to get ready for something. Interesting times. Here are the vaccines. You've probably heard a lot about them across the top here. I've given you the 4 that are the most kind of common you think about. Pfizer and Moderna were the first kind of 2 that jumped into the United States. These are exciting new mRNA technologies. Johnson & Johnson is the one that was more recently approved. This is a adenovirus vector technology, more traditional. And we're probably going to see AstraZeneca end up being approved for the US as well. This one is more other places, including the UK and Canada and other places. And I don't want to read the whole chart to you, but the technology is really cool on these mRNA vaccines, because basically what's happened now is that we can create mRNA that's going to code for the spike protein. We wrap that in a little lipid nanoparticle, and when you get that injection, that mRNA then tells your cells, your ribosomes, to create spike protein. And so you start doing that, and then your B cells detect that spike protein and start creating antibody. The only real difference with the adenovirus vector is that you get a virus. Adenoviruses are typically associated with head colds and things like that as well, but they've taken a non-replicating adenovirus vector, has no danger with it at all, and they've spliced in that spike protein sequence. And so there's just like an extra step. When you get that virus, that vaccine, it infects your cells. And so there's an actual infectious process, and then the same thing happens. The mRNA directs the ribosomes make the proteins, the spike proteins kind of trick your B cells into creating antibody, and you're protected. There is some advantages, right? So Johnson & Johnson's 1 dose, you can do 2 doses, but 1 dose has been shown, and I've added it into the chart. Importantly, it's showing 80+% efficacy at preventing severe illness and death, right? And AstraZeneca is around 70. And of course, these 2 have shown really amazing efficacy approaching 95%. And you may have seen some recent news that Pfizer is now showing that it's lasted 6 months and we still have nice high levels of neutralizing antibody. And here's what people have to know in the real world, because you may get these questions from your friends, is how long is it going to last, right? Everybody wants to know. We don't know. That's the issue of having an emergency use approved vaccine. Most of this in the past was already done. You never would have gotten the vaccine. You would have followed those clinical trials for 1 year, 2 year, 3 years, and known that, okay, this is going to last for 1.5 years. You're going to need a booster every 2 years. We don't know that because we needed to get it into the arms quickly so we could cut down mortality and issues. So we have to wait and watch. And what we hope is that that efficacy and that level of neutralizing antibody lasts for a year. I mean, wouldn't it be great if it was 3 years? So we'll see how long it lasts. And people will ask me, which one should I get? And my answer is the first available. You don't have the option here for Zeneca yet, but 80 and 95 and 95, Johnson & Johnson's fine. I mean, that's better than the flu vaccine you take every year. That's like 60 to 70% half the time. Remember, the goal is to keep you from dying and keep you out of the hospital. And that's what this is going to do. There's still a 5% chance here you can get COVID. It's not perfect. No vaccine is. And, if you had a choice, maybe you want Moderna or Pfizer, but you have to wait 6 or 7 weeks to get full protection. Here you have 80% after 2 weeks, one dose. So you have to kind of judge what you want to do. And in some cases, you may want to get that J&J into arms of people that you're really worried about, prisons, immunocompromised populations. You just want to get it out there and get people protected. So keep an eye on these because I think Moderna and Pfizer are going to be interesting technology to watch as we move forward to new outbreaks. And they are already producing clinical trials with some of the variant changes so that we'll be ready if we need them this summer or later. Okay, I'm running here at 4:45. So just wanted to share a few more quick vaccine because people are interested in this right now. This is literally a few days ago, April 4th, that I got this data. Look how well Israel's doing. They adopted Moderna right away and volunteered to be a full country that would take as many as they could. So they've been rocking and rolling early on. The United States is not doing too bad with respect to who's received at least one dose, around the 30% mark. That's just one. When you look at these two side by side, this is one dose, this is one dose. This is showing you total numbers of people. 106 million. You can see these other countries are doing pretty well. And then you see the disparity when you get even Canada. I have colleagues in Canada that are just flipping out because they haven't had a lot of approval and moving forward on vaccines. So they're still struggling with outbreaks. So there is disparity across the geographic spectrum for the haves and the have-nots. Hopefully the US will continue to donate like other countries to those pools and supplies of vaccines to get it into other countries. Remember, it's a global pandemic. Every single person, or as many as we can, need to get that vaccine to help curb this outbreak and this pandemic. And just a couple of more quick shots to kind of show you the heat map of the world. And it does show you the disparities here. The green, the darker green is higher vaccinees. The lighter gray means you don't have much going on. So we need to do a better job at getting this vaccine into poorer countries or countries that don't have supplies yet. And this quick arrow, just to point out, this was as of April 4th. We're pushing 20% fully vaccinated and hot off the press. Now this is all if everything is perfect and we have all the supplies going and we have everybody taking the vaccine as quickly as possible, that we could reach as high as 70% June 17th of herd immunity, end of July 90%. Now this is all adults 18 and older. One of the articles I pushed out through the conversation and things I've been talking about for months is remember these vaccine makers didn't get children safety efficacy as quickly as adults because the risky populations were the elderly. And so they're doing those right now. Pfizer just announced that their vaccine is 100% effective for 12 to 18-year-olds. So that'll probably be coming quickly. But we really need to get down into those younger ages as well if we're going to reach herd immunity because they are asymptomatic carriers in many cases. And we're going to eventually need to get down into some of those younger populations. But we're on the right path. We're doing a good job. What I worry most about is we might reach a threshold when we start running into vaccine hesitancy and people that don't want to accept the vaccine. But hopefully that won't be as bad as we see. A lot of people seem to be excited to get it and to get this thing, behind them. I grabbed this yesterday because I just thought it was interesting. They're already, you'll notice the University of Texas has got some press here. Jason McClellan's lab and his colleagues have put together a new design that's based on a modified version of this spike protein. And it has six modifications, not just two, that literally lock up that spike and create antibodies before the virus can invade cells. So this means almost a preemptive strike, pre-viral entry. That's kind of cool. And so I want to keep an eye on that. That might really help down the road if we keep doing that. And Moderna recently announced, I was kind of wondering if this would happen. I'd been talking about this months ago, that it would make sense for someone to create a SARS-2 and a flu combination vaccine. That if we need it, that if it becomes similar to flu and you need it every year, that we create that combination so you don't have to get two shots, you just get one at a time. That would help with distribution and cut down on people's hesitancy. And lots of money, right? So we've thrown lots of money at this. There's my soapbox. Public health matters all the time to everyone. It's not political. It's not geographical. It doesn't matter how much money you have or what color you are. Viruses and microbes will infect you without bias. They do not care. We need to remember that. We need to treat this like Department of Defense funding. I've been talking about this for about 2 decades now. Think about the microbe and how many people it's killed. Not just this pandemic, but going backwards. Microbes have killed more people than most terroristic events, most wars, and yet we don't fund it like we do Department of Defense funding. Public health should be part of that thought process as we move forward. If this pandemic didn't wake up politicians to do that, I don't know what will. And so I'm hopeful that they'll start thinking about this moving forward. Okay, Uriel. This is a transition. There's about 10 or 12 slides here kind of talking about scenarios moving forward. Are we okay to continue to do that? I know it's maybe getting a little thick and a little long. So if you're out of time and you need to leave, I understand. But I think I'll push forward. I should be able to get through this in about 10 or 12 minutes.
For
And it's
sure.
just kind of, I'm sorry.
I said no, for sure.
Okay, great. This is just talking about kind of what's coming next, possibly, right? It's hard to predict with certainty what's coming next. In fact, it's really impossible. All we can do is our best. And so even before this pandemic in 2017, and even prior to that, WHO, CDC, Public Health England, I mean, places all over the world have been watching blueprints, different diseases, different agents for emerging and re-emerging infections. And they put together lists. So these are things we've been watching for years, right? And you'll notice even in 2017, look, there's SARS, right? Because we were worried about a highly transmissible respiratory agent. There's arenaviruses like Lassa and filoviruses like Ebola and Marburg. I mean, these are some of the scariest things on the planet. There's Zika, which kind of fell off the map, and chikungunya, you might remember that. All these are mosquito-borne viruses. And so we've been watching these, and we've been, pushing that we need more help in building infrastructure and surveillance and personnel and professionals. And some of the others you don't see listed there, like malaria and HIV and TB, that's because they already have major disease control and research networks. They're almost isolated at CDC. There's a lot of money and a lot of funding for HIV, for example, and malaria. So they don't really get put into that big list, but they are kind of in the thought process, right? Because they still could potentially be problematic. The other thing, and this is my world of research a little bit, is remembering that we have this ongoing threat of antibiotic resistance. This is a huge problem globally, and I'll give it a little bit of conversation here as we go through it. massive antibiotic resistance issues. And this has been going on for a while now. I'll often talk to students and others that are not in the public health realm about how critical it is that we watch all legs of the stool. So animal health plus environmental health plus human health equals one health, right? Animals are often sentinel surveillance tools when we watch animals for different agents and they jump into humans. The environment's important to watch water and other things to see what's going on. So these are all really important in this One Health initiative. If you're not familiar with the One Health initiative, I would encourage you to check it out. It's got its own, platform at CDC and the WHO, and it's something that's kind of a global effort to think One Health. And just a reminder, some people talk to me about Ebola, right? Remember 2014? We were freaking out about Ebola, and we had the cases come into the US from travel. And I'm not going to go down the road of telling you everything about Ebola, but it's a nasty virus. It kills 70 to 80% of the people that it infects. It messes with the coagulation process of your blood, so nothing clots and you bleed from all sorts of places. And it's very deadly. And the primary issue with it is that it impacts healthcare workers or anyone that takes care of people that have died, because it is primarily bloodborne transmitted. And so what's interesting about this, you might remember this in 2014, we had a couple of people that died in the US. We had a librarian visiting the United States and a doctor who had treated Ebola patients in Sierra Leone. And then we had a couple of American nurses that got it and so forth. But only 2 people have ever been infected with Ebola while on American soil, and neither died. So I would make the argument that even though everybody's worried about Ebola, and we should be globally, that one of the reasons SARS is much more complicated to control, or something like influenza, is because it's respiratory, it's airborne transmission. It's much more difficult to transmit Ebola because you don't have people slinging blood around or body fluids and getting it into your eyes or into wounds, or using needles and getting it that way. So in a sense, Ebola virus disease, EVD, is a little more less concerning in the United States than it is elsewhere. We absolutely have to watch for it. We absolutely have to plan for it. But in many ways, you could control Ebola much easier than you can SARS-2 or a really nasty flu strain, because it's just easier to do contact tracing. It's easier to do prevention. There's now a vaccine for Ebola that's been working and testing in Africa. So there's a lot of progress there. So Ebola, while scary and very deadly, is actually not as easy to transmit as something like SARS. Quickly, again, people are watching these different categories. So if you're a microbiologist or you have someone interested in this, or a medical laboratory or public health laboratory person, we talk about category A, B, and C pathogens. A's are the highest worry, B's are the second concern, and C's are the third concern. You'll notice A is super disseminated, easily transmitted, and super high mortality rates. So we worry about those a lot. B is the second highest. They're kind of moderate morbidity, kind of low mortality. Also for A, there's no vaccine. There's usually no prevention tools at hand. They're pretty dangerous. And then as you get to B and C, we actually have therapeutics. We have antibiotics, we have antivirals, we have vaccines that we kind of use them with. C is the kind of down the list, but we worry about bioterror agents in this list because they might be easily mass produced and things like that. And again, not to read this to you, but just if you're interested, here's some of the examples of A's, right? So hantavirus, anthrax, Lassa fever, Ebola, all the things you would expect up here. Category B, these are still pretty nasty, but many of these can be treated with antibiotics and other things. Some of the mosquito-borne viruses like Zika, Eastern equine encephalitis, and so forth, chlamydia, right, brucellosis, and so forth. And then category C, I'm going to talk a little bit about some of these. One I work on a lot, rabies, is down here in category C, but a lot of the others you may not know a lot about. Some of the tick-borne flaviviruses, Powassan fever, There's some interesting agents down there that we kind of keep an eye on. So two things I'm kind of keeping my eye on all the time. One of them is flu, right? I mean, I'm always going to be looking across the landscape, but influenza is always a concern because of its ability to reassort and create new subtypes. That's why you see the next H5N1, H2N9, whatever it's going to be. It has a high potential to reassort, and they just love to reassort in swine and birds. And so we have this, seasonal movement of influenza around the world that can be potentially dangerous. Remember, that's what caused the 1918 pandemic, 100 years ago, killed all sorts of people. Think about that time. They had no vaccine. They just had to weather it. They just had to ride it out. And then here's one, I don't know if you've heard of this. This is one I'm keeping my eye on. This is called African swine fever. It is killing millions and millions of swine in parts of Africa and other parts of the world. It has not been seen in humans yet, but whenever I see things like this going on and just wiping out entire animal populations, I'm worried. Because in those parts of the world, people live closer to animals. Sometimes they live in their houses or at least nearby. Healthcare access can be problematic and so forth. So you worry about those species jumps when you have that type of behavior going on around the world. So those are two that are kind of on my radar, as well as many others, but these are two that I've been paying special attention to. And just for, just to put you in a nice paranoid as we finish up here, look at the United States. I mean, this was Dr. Fauci's model here that he built many, many years ago. This has been used a lot. So you could actually update this with more things. But I always talk to people, people will say, all these things are happening in Africa or happening in Asia or China or whatever. Look at the United States. I mean, we have a lot of stuff going on here, from Lyme to major resistant antibiotics, to hemorrhagic E. coli, to monkeypox. I mean, we've had some serious problems in the U.S. We just haven't had a major epidemic. The last one I dealt with was West Nile virus that really burned across the U.S. in the late 90s. Going to keep an eye on this One Health for you as we kind of get close to the end here. And I want to leave you with one thing about this ongoing slow burning pandemic. This is kind of something I'm passionate about and talk to people about, and that's antimicrobial resistance. This acronym stands for healthcare associated infections. In other words, you go to a hospital or to a nursing home or to a clinic and you pick up an antibiotic resistant bug. Be careful, be wary of these things, because there are some now out there that are absolutely terrifying and can kill you. This is kind of the current map. Even though this says 2014, this is still pretty accurate with respect to annual numbers. You see, this is due to all antimicrobial resistance. And when you look at the predicting models, and I talk about this a lot, WHO and other predicting models have shown that if we do nothing to curb this problem of antimicrobial resistance, we're going to have an economic impact of about 100 trillion, 10 million deaths, and one new infection every 3 seconds by 2050. That's this bubble over here. Right now it's about 700K. That's where we're headed. It will outpace cancer. It will outpace diabetes. It will outpace diarrheal disease globally. This is a problem because it's kind of a hidden, slow burning pandemic. 1 in 25 people in the United States obtain healthcare associated infections. My father has one. He has MRSA. I've been dealing with that for about a decade now. It reoccurs. It's absolutely a problem. And so you want to stay on top of that with respect to making sure, if you think you have a bacterial infection, ask for a diagnostic test so that you get the correct antibiotic. Empirical treatment, while sometimes necessary in an emergency room, is not the perfect way to do this, all right? And so we want to be careful and judicious with our antibiotics and even our antivirals and how we move forward. So I know we've run really long here because of our late start. I don't know if we have a lot of questions, but This is some of the things I often talk about. I think the US, I think we could all agree that we have some issues with national strategies around what happened this past year, especially with testing and with PPE and with making sure we have vaccines for everyone around the country and around the world. And boots on the ground mean people. If we don't get people in public health and medical laboratory and epidemiology pipelines, we're in trouble because many people are retiring, and a lot of that funding has gone away in the 90s and early 2000s, and there's not a lot of middle professionals. We have a lot of on the front end, and we have a lot on the back end retiring, and not a lot of people in the middle. And so I'll kind of leave it at that. We need more experts in these areas and more funding and career options for those to build into pipelines. Got some references if you're interested. You have a lot of them. Some great references here to check out with respect to mapping and resources and so forth. And I'll stop there, and I thank you for your attention, and I'll see if we have any specific questions we might want to try to answer for you.
Thank you so much, Dr. Rohde. That was very information. It's full of information, and I appreciate the take that you took towards the end, where you really go into where we're moving as a population. I did have a question that someone brought up. So someone read recently that St. Edward's University in Austin will be requiring faculty, staff, and students to get vaccinated in order to return to campus, with a few exceptions, of course, for people who have health, religious, or other kinds of reasons for not to get vaccinated. They want to know what your take is on policies like this.
Yeah, great question. I get this quite a bit. So the quick answer is that in state institutions like Texas State University and public schools, you cannot mandate that. And the president and the provost at our university have said that publicly. That is a legislative item, an action that must happen. Remember, if you've come to college recently, you had to get the meningitis vaccine because living in dorms is a risk for that. That is a legislative mandate, again, minus the religious and the other exemptions. So it can be done, but it would have to go through the legislative arm of the government in Texas. St. Edward's is a private university, so sometimes they can do what they want. That doesn't mean everybody will agree with it, but they can sometimes do those sorts of things, and then they may have to work through the kinks if they have some blowback. As a public health professional, again, I'm always going to advocate for vaccination, and I just will. I've had every vaccine that you can imagine working at CDC in the public health department. I know there's some issues. There can be side effects. There can be risk. Certainly wouldn't want someone to take that risk if they have serious concerns and medical issues, and perhaps even the religious exemptions and like that. But in general, I am a proponent of vaccination. They have stopped and helped save more people globally than probably any tool in our toolbox, going all the way back to smallpox. It's just, again, it's irrefutable if you look at the numbers, how well it saved lives. I remember my grandmother lived to be 101 years old, and she used to talk about how they held parades for the polio vaccine and things like that. And it's just interesting that in about the last 30 or 40 years, we've gone kind of different as a society. We have a lot of people questioning vaccinations, and I often say that you're right, and I'm fine with that. But I think it's because we're spoiled of how well they've worked. If we would have lived 100 years ago, probably be more people lining up for that vaccination because people were dying all the time. So it's like clean water to me. Would you not drink clean water? That's public health. It's interesting sometimes, and that's another conversation. But I think St. Edward's can do it, and other private universities can do it, but they may have some pushback with respect to those exemptions.
Thank you.
You bet.
Someone else is asking, do you know anything about vaccination passports and what we can expect from that?
Yeah, another good question. I actually got interviewed about that recently. I think it's an interesting question, and yet it's going to have some problems. Again, as a healthcare professional now, there are major issues with HIPAA and health security of your data. And if you think about it, if you kind of really think through that, people could be treated differently. What if you didn't want one and nobody lets you fly? I mean, what if you didn't have one and they wouldn't let you come into a restaurant? I mean, it could create some problems. But during a pandemic, during a public health emergency, I could, again, as a public health professional, as a healthcare professional, I could see the utility for travel in maybe some instances where you might say, if we know that everybody's vaccinated that's getting on this plane or attending this event, we're going to be a lot more comfortable in allowing that to happen. So I think it's going to have to be a kind of wait and see and how the public reacts to that. Again, personally, I don't have a problem with it. I would be happy to share my vaccine history. I do it when I travel abroad. I often have to. Um, but I think a lot of people are going to be hesitant on that. So we'll just kind of see what happens in the United States moving forward.
Thank you. Also, I had seen in one of your slides that there was a variant of the virus in Seattle.
Mhm.
Um, and I noticed that you said it was extinct. How was that possible? Or how does a virus go extinct?
Yeah, so that's a great question. So, I mean, viruses, again, like many things, will continue to propagate through a host. That's ultimately, viruses must have a host to replicate. Many of you probably know that. They can't grow in the environment like bacteria or parasites or things like that. So, if the virus runs into different host immune systems or different environmental factors that don't allow for entry and propagation, they can die out. They can go extinct. Much like if you immunize everybody, like we did for smallpox, and you basically make a virus go extinct. Um, I would actually say, again, that one in Seattle that mentioned there, it's an interesting thing, but I wouldn't swear on a Bible to that until I looked at the population enough because it might still be piddling around there. It's just not the dominant strain, and it doesn't seem to be showing up with any illness or any concern. So again, unless this is the statistical answer. If you can't, sample almost, a majority of the population, you can't really say it's totally extinct, but it's basically at low levels and probably not circulating in high numbers. Good question, though.
Okay, thank you. I'm not sure if anyone else wanted to share their thoughts or questions.
Okay. Well, thank you guys so much.